Hello, everybody, and I'd like to welcome you to our Outbreak Management Advisory Board. Thank you to the board members that have joined us and also those watching along at home. We've got quite a lot of agenda items for today as normal. So I'll ask Tracy first to go through any apologies that we've had. But as I say, just to welcome you all to the meeting today. Tracy.
Thank you. So we have apologies from Philip Allett, the Police, Fire and Crime Commissioner, and Caroline Blackburn is substituting. We have apologies from Amanda Hatton at the City of York Council, apologies from Phil Netton from the CCG, apologies from Mike Padgham from the Independent Care Group, and Beverly Proctor is substituting, and apologies from Lisa Winwood at North Yorkshire Police with Michael Walker substituting.
Thank you very much for that, and welcome to Beverly and Caroline, who I can see, and I'm sure, as you say, a few others might join us later in the meeting as it progresses. The first agenda item is then declarations of interest, so I'll give everybody a couple of seconds in case there are any additional interest that you want to declare in relation to the agenda. I can't see any hands, virtual or otherwise, so nothing in addition to declare today, and that takes us straight on to item 2, which is the minutes, which was the meeting that we last held on the 9th of June. And just whilst everybody has an opportunity to look at the minutes again, there was one matter arising at the last meeting, which was the request that the communications team spoke to the council enforcement and environment teams about the anti-vaccine and anti-COVID stickers that were appearing in different places across York. I've heard that they did have that conversation with frontline staff who will continue to keep an eye out for such messages and remove them as appropriate. And they made a plea that we said if any residents or any stakeholders did see any, could they please report these, and they can do so on york.gov.uk/report graffiti. And I know that the council will be using its channels to get that message out there as well. So on that, I'd ask you all if you're happy to approve the minutes, and if you don't indicate that you want to speak and you don't shout now, I'll take that as consent with the minutes. And I saw a few nods there, so thank you very much everybody for that. That then takes us straight on to agenda item 3, and that's a presentation on the current situation in York, and Fiona is going to lead us through that presentation.
Thank you, Chair. So yes, I'm going to, as usual, share some slides in terms of what we're seeing at the moment in terms of COVID in the city. So hopefully you can see those popped up now. So what we are seeing at the moment, as I'm sure many people are aware, is that we have seen an increase in cases of COVID over recent weeks. So as you can see there, it has been quite a sharp increase. Our 7-day rate per 100,000 population currently stands at 411.6. So it's well over 800 cases that we're seeing over the period of a week in York at the moment, and that is now above both regional and national average rates. And then, as you can see from the chart on the left, in terms of how we compare with our regional neighbours, we are now the 4th highest within the region of Yorkshire and Humber. So it's quite a different picture to that which I presented at our last meeting, where we were at the bottom of that graph. So one of the things that we closely monitor is what our case rates are doing in the over 60s, as the more vulnerable in our population. And having stayed quite stable for some time, our rate in that population has also increased. So that rate now stands at 56.5, again higher than the national and regional averages. Although, you know, it does have to be said that in terms of actual numbers, they are still relatively small. So that's 28 cases in that group over the period of a week. We also monitor what's happening in terms of numbers of people who call NHS 111 with COVID symptoms, which gives us an indication of whether people in the community are experiencing ill health, ill enough to want to call and get some advice from the NHS. And as you can see, there has been a slow but quite a sort of steady increase in terms of the number of people who are going through to that service. So that tells us something about illness in the community. The other thing which we obviously look at is the number of people who are in York Hospital with COVID. So we had for a number of weeks been seeing that remain quite consistently low, so usually around sort of 3, 4, 5 people in York Hospital. What you can just see on the very right hand side of this graph is this is really just this week we have started to see an increase in numbers of in hospital. So currently stands at 15 in York Hospital. So it is low numbers, but obviously it does concern us that it has been a jump from, as I say, about 5 or 6. So we do know that York Hospital is the hospital that you would go to across the York and Scarborough Trust, but I do understand that there's only a few patients from Scarborough who are transferred into York at the moment. So I think that's something that we just need to be very aware of. We also look at deaths. So we have not at present seen any increase in deaths. So in the latest period that we're looking at, we have not had any COVID deaths. And when we compare that to deaths that we, for all causes that we would see at this time of year, we're not seeing any increase in deaths. And in fact, it's actually lower than we'd normally see at this point in the year. So again, that's a positive thing. But I think what I wanted to just do is to look at what we've seen at previous parts of the pandemic and just kind of help us to understand what we might be about to see or how it's played out previously. So this graph shows what we experienced through December and through January. So what we experienced in that part of the pandemic was that it was around sort of mid-December where we started to see our cases go up. The green line is what we saw in the hospital, and then the red bars are what we saw in terms of deaths. So when our cases started to go up pre-Christmas, we didn't actually see that increase in hospital admissions come until really the end of January, end of December, beginning of January. So it was kind of a 2-week delay before we saw those hospital admissions rise. And then actually we did see an increase in deaths at that time, but actually that was about, as those hospital admissions were starting to steady out, that's when we saw the increase in deaths. So it was about 1 month after we saw the increase in cases. So I think a couple of things to note as well, the actual number of cases at that time was a lot higher. So as you can see on this graph, our kind of highest day of cases was nearly up to 250 cases in a day. So when we look at what we're seeing now then in comparison, so our cases we're not yet seeing quite as many. So our highest day has been almost up to 160. And we've really started to see that increase in cases kind of around mid-June. That's where we saw those cases starting to go up. So if we take that same approach of expecting a 2-week delay before we might start to see hospital admissions, as you can see from the green line, we haven't seen that this time. So as I say, we've had a slight increase that you're seeing there on the right hand side. It's been a much slower increase. If we were seeing the same thing that we'd seen in December, we would have expected by now to have been well into those hospital admissions going up. So I think, you know, as we're hearing on much of the national coverage, the link between cases and hospital admissions is definitely much weakened, although it's, you know, potentially not gone completely. Obviously, in terms of any increase in deaths that we might see, we're not sort of out of that month-long period yet, but given that we haven't seen a big rise in hospital admissions, we hope that we're not going to see an increase in deaths. So then just to talk about, so where are the cases that we're seeing at the moment? So what you can see here is the rates per 5-year age bands, but also the numbers, just to give you the bit of context. So clearly the highest rate of cases is in the 15 to 24 age group, and you've got the numbers that equates to there. So just to dig into that a little bit more, because obviously if you're in the 10 to 14 age group, for example, you might be a 10-year-old at primary school, or you might be an 11-year-old at secondary school. So by far and away, that we have had cases at primary school, but that's the smallest part of that age group. So it's secondary age range is where we're seeing the cases, but actually in that the 15 to 19 and the 20 to 24 group, it is the majority of those are in the 18 to 21 age range. So I've put university age range, but obviously not everybody in an 18 to 21 age group is a university student, but it just sort of highlights where exactly it is in that age group that we're seeing the cases. So obviously these are the age groups who haven't potentially had a chance to have a vaccine yet, or have only just very recently had a vaccine. I think one of the other things though to point out is that we've probably seen increasing cases across all age groups, so it is seeping into the older age groups, but what we're learning about the vaccine is that it potentially leads to less serious illness, so that will by and large be a more vaccinated population in the older age groups. Just a little bit on variants of concern. So I think when I presented this last time, it was about half Delta and half Alpha variants in York. It's by far the Delta is the dominant strain within York now, almost to the point of not really talking about it as a variant, but that is just what COVID in York is. And so we're still getting some cases of the Alpha variant, but probably the Delta is squashing that. But it's also worth saying that one of the reasons why we need to try and keep our case rates as low as possible is that there is still this worry about, as a virus has more room to spread, then there's more room for it to create new mutations and variants. And as you can see there, we have had a couple of the Gamma variants. One actually has been confirmed now, the other is still a provisional. So there is still this heightened surveillance around other variants, which we know less about, and obviously a concern about whether the vaccine is resistant against those variants as well. And then just finally, a couple of slides just in terms of our local contact tracing. So you'll know from mid-April, we took on doing all of the contact tracing of cases in York, known as Local Zero, whereby they pass to local team at 0 hours. And as you can see, we've been able to contact well over 90% of cases on most weeks and do that contact tracing with them. We have over the last few weeks as well also been doing a pilot to contact people who have been contacts of cases, so that's been going well, and will be under discussion as to whether local areas will continue to do that or whether it passes back to the national team. And then just sort of supplementary to that, obviously with the rising number of cases that we've seen in York, just kind of presenting that data in a slightly different way, which shows you in terms of the number of calls that the team have had to do over recent weeks has kind of shot up, but really positive that they've been able to still contact a high number of people. So I was going to stop there today. I haven't presented any of the usual kind of vaccine data because that's going to come under the other agenda item, but happy to have any questions on that.
Thank you very much for that, Fiona. So I'll open it for any questions or comments from any colleagues. I was going to ask one myself first. Fiona, you talked about the pressure on the hospital with that, as you say, that slight increase. And similarly, I understand that has been put on other services like Yorkshire Ambulance Service. I also would imagine local GPs, and whether there's anything you wanted to say on that, or whether Steph or Sally wanted to come in, for example. Fiona.
Yeah, so we do understand from colleagues that NHS is under pressure, and it's really from a number of reasons. One, because there are still some backlogs of people coming through from when they didn't present earlier in the pandemic, but also because there are a number of people who are isolating from having been either a case themselves or a contact of somebody who has COVID and then can't work. So in terms of staffing levels, there's a lot of pressure on teams there. So we certainly don't want to give the message to people that they shouldn't contact their GP or A&E if they need it, but certainly we're trying to give those messages out about the appropriate place to go with any health issue you have, which might be a pharmacy before a GP, etc. So yeah, it's really, really important.
Thank you very much. Sally or Steph, was there anything you wanted to add at that stage? Don't just before I move on. If not, you can always come back in later agenda items. James.
Hi, yes. Fiona, obviously you mentioned that there was a slight increase in the over 60s who were getting getting COVID. I wonder if there was any kind of data being looked at as to either whether or not those had the vaccine, and if they had it, whether they'd had it a long time ago. So was there any indications the vaccine was kind of becoming weaker over time?
Yeah, so there are various national studies going on looking at vaccine efficacy. So we don't kind of get that data at a local level. I mean, we know for sure that there are people who have been doubly vaccinated who still get COVID, but the evidence seems to be suggesting it's milder. And then, some of those national studies sort of showing that there's less it's less likely to be transmitted from those people. But I think that is one of those kind of answers for some of the bigger national studies to give us some better data on.
Thank you very much. Mike, I understand that I can't see a hand, but you might have sent a message asking to come in and speak. So please do.
It was really just whether it would be useful just to get a view from general practice about the pressure in the system. And, I think what we're seeing is that general practice is under significant pressure. The data we have around total demand is probably higher than we've ever seen before. So I think I just really echo Fiona's comments around accessing healthcare. Clearly it's there for people who need it, but the system is under significant pressure.
Thanks for that, Mike. Sally.
I was probably just going to come in and say the same, and I think the other point I would make is that one of the other reasons that we're perhaps under pressure is because we're seeing a lot of respiratory illnesses at the moment that we'd traditionally see in winter months. And I suppose that's because people haven't been socialising for a long time and their immunity to various other viruses has dropped. So we're seeing a lot of both children and adults with typical illnesses that we would see in winter, and we're seeing probably winter levels of activity. So I suppose just a reflection that when we're thinking about the 19th of July and masks, one way to try and mitigate some of the impact is to continue wearing masks in crowded areas to try and not only reduce the risk of COVID, but also people being mindful of the fact that there are multiple other viruses and there is a lower level of immunity generally in the community to those viruses at the moment. So it will help also reduce that spread.
Thank you for that. Alison.
So my question's about the people in hospital, the 15 people. So I know it's a small number, so you might not be able to answer, but do we know on the whole, are these younger people and therefore not being vaccinated, and do they have underlying conditions? Can you answer that or not?
Yeah, I mean, it is a mixed picture, really, and obviously, you know, we don't always get that kind of patient level detail, so it's kind of more general in terms of a conversation. I know that about half of those are over 65, but the other half are under 65. And I know anecdotally that some are fully vaccinated, some not. So it is a bit of a mixed picture, and then, you know, there may be some underlying health conditions as well. So you know, it's different. We don't sort of get enough sort of detail to analyze that, but certainly it's yeah, it's a mixture. It's not just your typical older person with an underlying health condition.
Thank you very much for that, Fiona. And I'll go to Sian in a second, but I also know that when we get onto the next agenda item from Peter, that within that we'll look at some of those pressures moving forward, and I know what partners are going to be doing about that. Sian.
Sorry, I've put my hand down because I did have something to say and I can't remember what it was. I was listening to you and it's gone completely out of my head.
If you remember it again, just put the hand up again. So thank you all very much for the report and those questions. And as I say, I know in the next item, in a sense, that conversation will carry on. So agenda item 4 is the look forward that Peter's going to present to us, and then section 8 of this report in particular has some requests for the advisory board to consider. Peter.
Thanks, Chair. And yes, it does follow on from the data that Fiona has presented really well. And I guess this is what it says in the tin, in the sense it's a look forward. And the paper was included in the pack. I won't go through it in absolute detail, but I will just quickly run through each section of it. The paper starts by explaining some of the models which are used to look forward in terms of particularly COVID infection rates. I'd say at this point, you know, the old adage that all models are wrong and some are useful. None of these models will give a precise indication of how many cases there will be in the city in 2 to 3 weeks, but they do help, and they generally have been proven to be in the right ballpark as they've gone forward. And the models were suggesting that the first couple of steps of the roadmap wouldn't have a significant impact on the number of COVID cases that were suppressed quite a lot by the early in the year lockdown, and that was proven to be right. But the third stage of the roadmap coincided, as people will know, with the rise of the Delta variant and its increased transmissibility. People will remember that the reproductive number was often talked about. It's estimated that the Delta variant has a reproductive number naturally of about 7. One case will generate 7 other cases if there are no other mitigating factors like social distancing and vaccines in place. Now, obviously, they are, so it's less than that, but it does go to show that the Delta variant is a significantly more transmissible variant, hence why, as we unlock, the case numbers in the models do start to go rather high. The second, the third and the fourth sections of the paper just outline a little bit what we've seen so far in previous waves, and I won't go over that because Fiona's done a great job of showing that data and how that has looked, but hospitalizations really have tracked cases with that 2-week lag, and deaths have tracked cases with the 1 month lag. And if we look at in section 4 what the models are showing just over the next month really for York, suggesting that our reproductive number is probably over 2. So one case will generate 2 or so more cases under the current restrictions, and then the lifting of restrictions that is coming obviously on the 19th of July is a different picture. But in terms of what that looks like for York, if you think that at the moment we are at over 400 cases per 100,000 population, so that's looking in a week's period at about 800 cases in York. The projections are that potentially we're looking at more like 750 to 800 per 100,000 by the end of this month. That is our January peak. It's a little bit above our general peak, and actually that is the central assumption in the model, but the model has a high and a low assumption, and the high model is twice that amount again, so twice the number of cases every week than we were seeing in the January peak. Now again, that is a model and it's not a crystal ball prediction, but it is showing that the only thing that really has stopped previous exponential rises in cases has been the advent of quite widespread restrictions on our movement, and we are just about to go into a period in which opposite to that, our movement as a population is becoming less restricted. And so that is why people will be hearing in the headlines that number of 100,000 cases per day, which is significantly higher than we got in the January peak nationally. And obviously we then factor in what vaccines do to that, which is to significantly reduce but not break the link between those cases and hospitalizations and deaths, as Fiona has outlined. But section 5 of this paper just puts, I guess, a little bit of caution onto what vaccines do for the population, which is to protect a large number of us, but by no means all. And the pie charts just really explain, just break down our population into various groups. There are, and there will sort of still be until national policy changes, 17% of York's population who cannot be vaccinated because they are not eligible for the vaccination. They are under the age of 18 or 16 with a long-term condition. And that group will remain until national policy is in place and they can contract COVID and pass it on. There will be those for whom vaccine does not work and it's not 100% effective. The most recent data suggests it's above 90% after 2 doses in terms of preventing hospitalizations, which is fantastic, but that does still leave a proportion of the population who won't be protected even though they're vaccinated. Obviously not everyone at the moment is vaccinated with 2 doses, and even when we get to where we hope to be by the end of the summer, where we've completed the vaccination program first stage, and we've got as many people double jabbed as possible. Some people won't have taken it up. It's never taken up 100%. And the pie chart in section 5, which lays that out, where we hope to be at the end of this summer, suggests that still there will be 31% of York's population, which is about 66,000 people, who won't be protected from COVID infection through vaccination. That's because they're not eligible, or they haven't taken it up, or the vaccine hasn't worked on them, that small proportion that do. And actually that is still a large amount of the population where infection is able to run through. Some of them may have natural immunity because they've previously been infected. And the age range of those 31% are the younger age range, who typically don't go to hospital as much with a COVID infection. But the paper goes on to mention other risks, which are not only to do with direct infection from COVID. And I think it's important to raise long COVID and long-term symptoms of COVID at this point. And some modelling that we have done suggesting that nearly 300 people in York already probably are living with the longest form of long COVID, that is symptoms lasting over 12 weeks, and a significant number of people who have the longer term acute symptoms lasting between 3 and 12 weeks, affecting employment, affecting health, obviously, and potentially affecting long-term health. And those numbers are only likely to go up with our increase in cases. There isn't any evidence so far that vaccination reduces the incidence of long COVID, but I think it's fair to say that that evidence is emerging, and it's harder to judge that, given you need the time period for vaccination to be effective, and then the 12 weeks to understand whether long COVID symptoms have developed. So that is still a bit of an unknown. And very quickly, just at the end, section 7 does introduce some other risk factors into this and widen out the look forward a bit from direct infection, mentioning flu. Flu in the most recent bad year for flu nationally, 2014 to 15, killed, we think, around about 40,000 people in the UK. It typically kills probably a quarter of that number in most years, but when you have a bad year, and that's not a pandemic year, it is merely a high epidemic year of flu in the winter. And interestingly, the year before that was a low year of flu circulation in the UK. And we've just had a low year of flu circulation. So we have to be prepared for higher levels of flu this winter, which may happen and may not. And obviously lots of preparation around the vaccination programme already in progress there. But we've talked already about other trends in healthcare, primary care, mental health care, community care, social care, all of them experiencing their own demand issues. Our colleagues at TUV, the Mental Health Trust, which covers York, telling us that they're seeing a larger number of people coming forward, both for common mental health disorders, depression, anxiety, but also acute mental health conditions, first episode of psychosis, for instance, a higher level of need in those categories. And so the last section gives a little bit of a risk analysis, really, which is available for people to look through. It's somewhat subjective, but showing that, you know, there are a number of risks for the city going forward around continued circulation of the virus. Risks that we will see a lower number of hospitalizations and deaths than we saw in the first wave, but still considerable a number. An unlikely risk, but still a risk, and with a high impact, that we'll see a higher number of hospitalizations and deaths than we did in the first. That is low likelihood because of the vaccination programme. And then risks to do with the flu, risks to do with long COVID, continued effect on the economy and on schools and education. Again, the risks are a variety of low and medium likelihood, but many of them are high impact if they were to happen. And then risks around other variants coming through, as Fiona has already covered, with high levels of infections and vaccine coverage. This virus is looking for a way to mutate so it can go and reinfect other individuals who will still be at risk. So the implications just on the last page really for OMAB are really around consideration and noting this report and particularly thinking about winter planning as a city, what preparations we're putting into place. It can't just be one sector. This isn't the job of primary care or secondary care or public health. This is all of us working together to plan for what might turn out to be, and not wishing to be a doom monger, it may not be, but it still might be a very difficult winter ahead. How we make sure we have the right things in place, we're working together as a system to meet those high levels of demand and to cope with COVID circulating and potential higher levels of respiratory viruses and flu within this winter period. So Chair, that's all I wanted to cover through the report, and happy to take any questions.
Thank you very much, Peter. I'll open the item for any questions or comments in a second. I think what I would say first, which might help steer some of those conversations, is that I'm absolutely sure the board can correct me if I'm wrong, but that the board members would endorse, as you say, you're noting of the potential levels of demand in primary care, secondary care, social care and mental health services across the city, and that we know that all partners on this call will have to plan for higher levels of winter support, and we'll be working together to do that, but we'll need to, and we'll continue to support and help the resources going in to deliver the vaccination programme, and as that moves forward, which I know is going to be the next item on the agenda. And I think the main question for me is that obviously the easing of the restrictions and the fact that we're in a position nationally and locally to even discuss and consider that is in no small part down to an awful lot of volunteers, businesses, key workers, the NHS and that vaccination programme to enable that to happen, which is great and has an awful lot of benefits for businesses, the economy and transport moving forward. But equally at the same time, there's going to be, understandably, a lot of people in the city who are quite anxious about those changes and about what the new guidance will be. And obviously we'll wait to get that confirmed from the government. And one thing I know that partners on this call have already discussed, the universities, the police, NHS colleagues and the council, is what we can do to make sure we're providing as much support and advice as possible to different groups in the population, different communities and different businesses as we go through that period of time, to try and make people considerate of all of those different factors, which I know that the population in York will want to continue to do. And so there's a group of communications officers from all of those different organisations that I know is looking at that, and I know that other towns and cities across the country will be doing so. But really, yeah, Peter, any particular snippets of advice for us, and then I'd be interested to hear others' thoughts on this call to just make sure that we get that right. Peter.
Well, I think one particular group that I'd highlight would be children and young people living with a condition which makes them clinically extremely vulnerable. And I think it's a group that us in the public health community, I've noticed, have been particularly concerned with. And the desire to make education as open as possible and to not disrupt it, whilst the levels of infection, as Fiona has just shown, are very high in particularly that 18 to 21, but quite high still in the secondary school age. Ways that we can support our education colleagues to support children living with those conditions to feel as safe as they can and to take the measures they can in place, and schools, I'm sure across the city, have been doing so, but it's probably a population who are feeling particularly vulnerable at the moment, given that vaccination hasn't reached them, and I think that there are sort of a number of other sort of at-risk groups, but it feels as if the levels of mitigation are there for them in a way that they are not for that group. So that would be one group I'd highlight, and I'm sure that the board would be able to highlight other ones within that. But I think particularly at the moment, until at least schools break up, there's 3 weeks in which a very, very harmful virus is really quite high levels within that particular age range.
Thanks, Peter. One of the things we've got later on the agenda is to consider adding a board meeting in August, because at the moment the next one is in September. And I know if we do, that the topic would be about the easing of restrictions and how York is responding to that. And I think actually at the same time as talking about that, it would be probably useful to get a report through from some of those communications colleagues from those different organisations about how we are talking to those different groups. So if that could be noted for that agenda, if we decide to have an extra meeting in August later, that would be great. Sian.
I'd like to thank Peter, because he reminded me what my question was, which was about long COVID and about whether or not we had the data. And I think from what Peter was saying, we don't have enough data yet to understand the full implications around double vaccination and protection from long COVID. But I think I've read a lot from people saying, I know that the deaths thing is the headline figure that everyone's interested in, but we mustn't underestimate the impact of long COVID. And we could have a significant proportion of our population trying to live with quite debilitating illness for a longer period of time. So I think there was some questions for me as well about what sort of messages are we collectively wanting to share. I think, again, Peter touched on mental health and anxiety. There are groups in our community that don't have the protection levels that others of us do. And I think for me, I would like us to really consider some very strong messages about what personal responsibility looks like. You know, where, because you care, get that mask on, look after people. I know I've seen general practice colleagues on Twitter talking about, does this mean that people will expect to be able to come into a GP surgery without wearing a mask? For me, no, I don't believe that's the right thing to do. I think there might be reasons why certain people can't do that, but those have been there the whole way through this. So personally, I would like us to put some really strong messages out there to reassure people that we want them to be as safe as possible and we will do the right things. And it's not about me protecting myself wearing a mask. I'm wearing a mask because I want the community I live in to be safe.
Thank you very much. Peter, any thoughts?
Well, no, I definitely think that the communications of this are going to be key, aren't there? And you're absolutely right, Chair, in terms of the level of collaboration we do have across communications colleges in the city is going to be a real asset for us, I think. In terms of healthcare settings, one example I'd think of in terms of the mask issue is pharmacists on high streets and thinking about the fact that people will be going into shops from later on this month, without having to wear a mask and popping into, the butchers, the bakers, and then the pharmacists, which is down. But that's a healthcare setting, and we probably would expect there still to be measures in place in the healthcare setting. So there are going to be very difficult and nuanced communication messages, and we're going to have to understand each other very well. But certainly, masks have been shown to be quite a low cost preventative measure. They don't interrupt society very much, and they do stop the spread very well, and they protect both you and the person that you might be around. So I look to Sharon in terms of that overall public health message, but I would be very much supportive of quite a strong line in York on masks, not being able to mandate, but being able to heavily recommend and being able to explain why to people in a really sort of coherent way that these are really useful protective measures.
Thank you. Charlie.
Keith, I was wondering whether Mike could come in. His hand popped up when long COVID was mentioned. And Mike, if you wanted to talk about that, I'm happy to defer.
It wasn't specifically about long COVID,
okay.
Charlie. So no.
Okay, then I've got a question for you, Peter, about modelling. I think Sir Humphrey in Yes Minister might have described the strategy set out by the government in the last couple of days as courageous, Minister. Because it seems to be a strategy to acquire collective protection or herd immunity through a mix of a very successful vaccination program and an acceptance of very, very high infection rates. Sajid Javid said, yeah, it could be 100,000 on the scale, and we're currently at 32,000, so 3 times higher than now. Are the modellers bringing into their calculations, which your modelling didn't, in that blue group, the unvaccinated group, the proportion of that group who will be protected because they have immunity following infection? Because surely that has to be part of the government's calculation. What do we know about that calculation?
That's a really good question, Charlie, and that's measured through the seroprevalence data, which is mainly taken from a sample from the from blood donors across the country, and it is it's a difficult equation, and I am no virologist or immunologist, but what I understand is that the current level of protection in the population, either from vaccination or from previously having an infection, is still lower than the herd immunity threshold, the level we have to get to before the virus will peter out in the population. And we don't have a precise measure of immunity length from past infection and from vaccination, but some really encouraging signs that people still have antibodies from past infection up to a year after having that infection. Obviously, we don't have the amount of time from having a vaccine to know that. So it becomes quite a difficult equation, and the modelling assumptions that all three of those sort of papers that I mentioned in my paper, they do take into account an assumption for immunity waning, but it is a very aggregate. They all assign a percentage of loss of immunity, and I can't off the top of my head remember what it is in each of them. But what they don't do is what I think you're asking, which is to look at that population age bands, particularly those yet unvaccinated, and to say how many of those do we consider probably have already had an infection. And that probably is the limit of my confidence in understanding the model. And to do that on a York perspective would be very hard, but we can, I think, get to the sort of the nub of your point in thinking about our those who are not eligible yet, those under 18s, and those who are not vaccinated yet, which are increasingly our 18s to 40s who have been later called for the programme. And we can assume a certain amount of immunity or a certain amount of protection from the virus for those. But the fact that at the moment we have gone in the space of 2 to 3 weeks from a case rate of, the 50 to 60s to a case rate of, over 400, does show that this virus has had somewhere to go in the last few weeks, and it has gone there and it has risen. And in that sense, at the rate at which the vaccination program is going, which is slow and steady, it's not putting on tens of percents every day, we will still have places for the virus to go at least over this summer. And after that, I think the crystal ball really does run out in terms of what might happen.
Peter, the question is, letting it rip, to give it a description, and accepting 100,000 cases per day, which the government appears to be prepared to accept over the next weeks. How quickly will a case rate of that level, concentrated in younger age groups, help us towards what I imagine the government is hoping for, to herd immunity?
It is a very good question, Charlie, and it's a question that I could perhaps go away and have a little look at. I wish I could run the models in my head now on that, but unfortunately, I imagine it's a bit of a complex equation. But it is something we could look at and see if there are any easy answers. Probably only best guesstimates rather than specific answers. But it is something we can come back to either you, Charlie, or to the board in general with a bit of a sense, because it does factor into the equation, doesn't it, in terms of our next couple of months planning.
Thank you very much for that. Now, just to say, we're about 10-15 minutes behind the timings for the agenda, and I've got 4 or 5 more who board members who'd like to speak. So I'm going to take everybody because of the discussion, but it was just to warn you if in case we need to go through some later items quite quickly, why. So I'll go to Mike.
Thank you. Peter, thank you for that. And you talked a lot about the actual infection rates, and we've also touched on long COVID, waiting list pressures in the system. But the one thing I wanted to talk about was mental health that you talked about. And I think when I saw models earlier in the pandemic, it showed that the sort of sequelae, the consequences of the pandemic would go on for a very long time afterwards. And I'm slightly worried about that. I'm certainly seeing in my practice significant levels of mental health. The last surgery I did, I think 80% of the people I saw had mental health problems, and I was seeing mental health problems amongst children as well. And so I just wanted to bring that to the attention of the board, really, and just urge us to think about that moving forward when we're considering resources and the pressure on the system.
And just a tiny update on that very quickly, Chair, is that I have been in conversation with TUV on the update of their model. It's not quite ready to share publicly, but they have taken the work they did last year, looked at what has happened in the last year, which interestingly is a larger increase in children and older adults than they were expecting, and actually a slightly smaller increase in working age adults, potentially because of the economic buffers of furlough, which may have helped a little bit around the economics of it. But they're looking to update that model, and it probably will be available for wider partner discussion later this month.
Thank you very much. Ian.
Yeah, mine was actually quite similar to the question Charlie's asked, so something that's been sort of dealt with or sort of answered in the sense we're not quite sure. But I think if you adopt the government strategy, it only really works if that immunity stays. And that's a question. I don't really see it being debated much, or much analysis in terms of, can you catch it again? At what point does it go? And, if you do reach herd immunity, what do you have to do to actually keep that? Because clearly I assume, got to keep vaccinating everybody, but I haven't quite seen, at what point do you, what are the actual steps you would really need to take to keep it, if you do get herd immunity, to actually keep it forever? And could it, or actually fail at some point?
And Ian, I just sort of answer that with I don't really know.
Yeah,
However,
no, in a sense,
I think thinking about flu as a model there does help. And to be really clear, I'm not saying that COVID and flu are comparable, because they're not. But flu has become a disease which we've not been able to eradicate through vaccination. And in that sense, COVID may head there. I think the flu pandemic in 1918 and in the 50s and in the 60s, they ended as pandemics, and we didn't live with them forever. So no pandemic goes on forever, but some disease become endemic and a population has to deal with them through vaccination and a certain amount of suffering, unfortunately.
Thank you very much. I'm going to go to Mark next, but before you do, Mark, as you're going to ask a question, I was going to take the opportunity to thank you, as I understand this will be your last board meeting with us. So just to say on behalf of all of us, thank you very much for your contributions, not just to the Outbreak Board, but indeed to Transport and across York. It really has been appreciated, and I know your place will get taken by the new managing director, but I'm sure colleagues would want us to minute our thank you to you. So without making it awkward, Mark.
Not awkward at all, Keith. Thank you very much. Just as I'm starting to speak, I'm now getting over it. Thank you very much. Very kind. My question is really relating to the conversation that Charlie started, and Peter, I think you referred to a crystal ball running out kind of period, but it was really just to understand where's that ceiling expected to be. So we're talking 100,000 cases a day nationwide, and whatever the equivalent will be in York. I think you mentioned 750 or 1,200 at the high end, but there's no lockdowns anymore proposed, no curbing measures. What's happening after that?
Yeah, and the crystal ball does run out, and I agree, Mark, that is a very difficult question, and one that will probably tax us. I guess we do then butt up against the natural thresholds of herd immunity and vaccine related herd immunity. It's measuring where those thresholds are, and understanding the immunity waning, which are the really difficult questions here. And we can probably only look with any certainty about the next month in terms of the cases, because we know that the number of people vaccinated will steadily rise. We can factor that in. We know that immunity won't wane much over the next month compared to last month, and the cases will go up using normal infectious disease models in terms of sort of the SEER model for infections. So we can put that in, and we can expect that a ceiling will be reached at some point and all diseases peak, and we can hope that happens at some point over this summer without too much disease running rampant and the long COVID effects not being too much.
Thank you very much. Sally.
Thank you. Just a couple of quick healthcare related reflections. One around the current national strategy and the expectation that cases are going to go up significantly. And although it's really reassuring to see that the numbers being admitted to hospital are still quite low, as numbers do go up, we can expect to see that number rise, albeit hopefully quite slowly. And I suppose we just need to be mindful of the impact that will have on routine healthcare. It doesn't take many admissions to mean that the hospital have to completely reconfigure how they do things. And again, that will result in further delay to some of the routine clinics and operations that we know there's already a very significant backlog. So there's a very strong drive to try and keep levels as low as possible so that we can continue to try and get on top of that backlog and we don't go backwards even further. And my other reflection was just around the comment around whether there's benefit in wearing masks subsequent to the 19th of July, and thinking about healthcare premises. And certainly there'll be some thinking over the coming days from a general practice perspective. And my reflection, I suppose, is that a general practice setting isn't the same as a shop, in that there's often very vulnerable people in a general practice. There may well be patients who are having chemotherapy, who are sitting next to somebody that's got a respiratory virus. So I think it's highly likely that collectively general practice across York will still be wanting to have some measures, even if those can't be mandated, and a very strong collective message to try and protect everyone if people are accessing general practice services. I think any support from the wider board would be welcome in that regard.
Thank you very much for that. So thank you, Peter, for that report, and to colleagues for all of those questions. So I think in our conversation, in a sense, we've agreed really to note the level of demand, the support that's going to be needed over winter, and the ongoing support for the vaccination programme. And I think what we've suggested is that if we agree to have an extra meeting in August, as well as to look at the impact on York in terms of the easing of those restrictions, to ask for communications colleagues who I know from the different organisations will be looking at this, to bring back their thoughts and reflections on what we can all collectively do to keep those messages going out as consistently as possible. So thank you very much for that. That then takes us on to agenda item 5, which is an update on the vaccination programme. And as part of this update, we're going to be hearing from Steph on the data around the vaccination programme, from Anita in relation to COVID vaccination inequalities, and also from Mike on Nimbus Care's vaccination programme. So hopefully I've got the order right, and we'll go to Steph first.
Thank you. So I won't go into the detail, but I thank everybody for accepting that the report is being produced as late as possible so you can see the vaccination rates increasing. But just picking up on some of the themes already, both this evening and at previous meetings, we continue to interrogate the data to address where vaccine take-up is low. I think there'll be significant evidence this evening about how the rates have improved in the wards that were shown as low take-up, and that was a message from this board that came through strongly previously. I wanted to talk about some of the things that we're doing regionally around the vaccine supply. We often haven't spoken about vaccine supply. It isn't something that's gone away, as we get to quite difficult logistical issues about making sure that first and second doses are being pushed out to areas with lower take-up rates than York. But we are playing you know, a timing game, particularly with second doses, and we now have a standardized 8-week second dose. So just to pick up on some of the questions, our over 80 vaccination rates across all York wards, so that's the city population. So over 80 is those with a second dose are 96%, 60 upwards, you know, they're varying percentages are over 90%. So that vulnerable group still has sort of up to 5% of those who haven't taken up the vaccine for full protection at second doses. So just to put some figures to respond to some of those points that Peter made on the modelling. So also just to give the board some assurance that regionally we're also talking about what we're describing as the third phase, which people might understand is the booster programme along with the flu programme, and also planning at a regional level any surge vaccination programme, again related to supply and how the system would rally round to support that. So before Anita comes on to the sort of inequality work that we've been doing across the system, and Mike talking about the data, I just wanted to put some real life examples of what we're experiencing in the last couple of weeks. So we have got general practices with staff who are testing positive for COVID. We have got staff in primary care who are isolating. So even in a vaccinated, well-educated workforce, the impact of the virus hasn't gone away. And this is undoubtedly going to impact on some of those restoration plans. So over the summer, primary care colleagues, CCG, took a lot of complaints from the public, from counsellors about primary care being closed, which wasn't the case, staff isolating, so that impacts. So we are sensitive to what we describe as the restoration of normal services going forward in the coming months. So Sally's referenced an increase in respiratory illness, particularly in children, also in adults. And we are starting that conversation with our practices about how we support them to share that message with patients coming into practices about wearing masks, maintaining social distancing, so that that environment is as safe as it can be and services can be protected so that they can continue at appropriate levels. And we know that demand is very high for services. We know that practices are just now finding their feet with responding to that demand, as our community pharmacists. So it's just to say that we are very much in planning mode for quite potentially very difficult weeks to come. So it is really helpful that we can talk about the really positive work that we're doing on the vaccine programme, but I don't think anybody close to our workforce feels that this is feeling particularly comfortable at the moment, as we plan and anticipate more pressures on the service in the weeks and the months to come. So I'll come back and just update on today's figures, because they are an increasing, improving position. But Mike did prepare the slides, and the report was prepared on the 6th, activity up to the 6th of July. So I'll pause there, and I'll come back in at the end of the trio of updates on vaccinations.
Thank you very much for that, Steph. Anita.
Thank you, Chair. Yeah, so obviously the report's been circulated prior to the meeting, so I'll not go through it verbatim, but just pick up on the salient points. Point number one is demonstrating around the system-wide approach that we've got to inequalities and the meetings that we engage in. And the importance of being at those wider meetings is to share learning, but also to see where we sit alongside our Humber Coast and Vale partners. And what I can say is that looking at our sort of like inequalities to vaccine uptake, we're not an outlier. People across the system are seeing exactly the same issues and challenges that we have, and it's good to be part of that wider system, to have that knowledge and, like I said, share learning of opportunities of how we address those challenges. Now, one of the things that, if you remember last time that I came, we had a little bit of feedback from people in York as to what are some of the challenges that they were facing around access. And one of those very real challenges for people were transport, the transportation to get to, say, like Askenbar as the mass vaccination site. We took that seriously, and we listened to what people were saying, and also looking at the data where uptake were low. And this is not just, like Steph says, this is a system-wide approach to looking at those issues. And one of the things that Nimbus, the CCG, and us in the local authority have supported with is the pop-up clinics. And that has gone a long way to address the issue of transport, because the pop-up clinics that you can see that's happening across the city, and those that are to come, they're in residential areas where people can access by walking or by using public transport. And when we promote these pop-up clinics, we give people the information on bus routes, etc., and whatnot, again to aid that access, the physical access into the pop-up clinics. So, we listen to what people do, and it's gone a long way to address the issue of being able to physically get to the vaccination. We're also looking at community pharmacies, because we know that again, it's a trusted access in local areas and ease of access again. And we've got currently the provision 2 in Axby and Acomb, and there are ongoing discussions for pharmacies to come on board. I also talked last time and again about the contact phone calls that we set up in CYC. However, if you think back to Fiona's slide about the activity for our contact tracers has exponentially risen this last couple of weeks. So we've had to put the phone calls that we're doing for people that are hesitant about the vaccine on hold. But I'm pleased to say that, Nimbus have done a lot of work around those contact phone calls in the meantime. We will, of course, stand up our contact tracers as and when capacity allows. And that's to have that really one-to-one discussion with people around their own hesitancy, whether that's, anxiety, needle phobia, or again, some very logistical problems we need to know, then we can address those very, very detailed issues. We rely very heavily on comms, and that's just not comms in CYC, but again, across the board, to get messages out, and targeted messages to where they might help people understand and have informed choice, because vaccine is a choice, it's not mandated. And we have weekly meetings to understand what the current issues are and to be able to respond in a timely manner. And then we've got some specific actions for targeted groups where we could see that the access to vaccinations may be an issue. One of them is around vulnerable women. There's already been one clinic delivered, and there's a further clinic arranged. And around our homeless population, there's been a clinic today and another one on the programmed in for the 9th of July. And I'm pleased to say that the feedback is that we've had 100% uptake for first dose for that population. So these things are working. We are getting to the people that are very vulnerable. There's been a lot of discussion around access for our traveller community, and the CCG are continuing work with understanding what is required for our travelling community, and North Yorkshire Council looking at how they reach the community travel, knowing that there are a couple of different annual gatherings that people go to, whether we do messages there and can we link into that, because they're coming from all different parts of the country, and that's knowing that population and knowing the community and where we can reach out to that population. And then around ethnic minorities, again, last time there were a lot of concern about how we reach uptake in certain minorities, and we know that our Chinese population were, maybe we're finding access difficult. And I've had conversations with a representative from our Chinese population. There is no resistance to vaccination uptake from that population, and indeed we're supporting everyone on ease of access, whether that's understanding the NHS system of how to either book on or access through a pop-up site, or looking at how we have translators on site and working with volunteers to be able to do that. So that's for all minorities that might want that extra support. And in the last page of my report, and again, apologies for the data being old, because it's fast-paced moving, the data. I mean, as we speak, there'll be hundreds, thousands of more people being vaccinated as we speak. But what I wanted to demonstrate on this slide, there were some concerns around wards that have got low uptake. And through the efforts, collected efforts through Nimbus, through the CCG, through public health, the volunteers, everybody that comes together to reach out to communities or make access easier, we can see that the uptake in those wards that had low uptake, although there's still still a lag, the uptake has increased. And it's increased at a faster rate than some of the wards. So all in all, I think it's a positive picture. There's a long way to go, and like I said, everyone's tackling these problems. And I think this is a case of chipping away at some of these, for us, challenges, and understanding what the challenges are for people. And it's going to be a slow process, I think, to reach a lot of people. And as I said, vaccination's voluntary. We may not get everyone because they may choose not to, but the people that, by far the majority of people, want to come forward, but it's our duty to make that access easier, and it's our duty to understand how we do that, and that's the work that we're on with at the moment. So I'll pause at that point.
Thank you very much for that, and I'll hand to Mike.
Yeah, thank you, Keith. I'm just going to pop up some slides just to show you a little bit of data to begin with, if that's okay. So the vaccination program has been in full flow now since December, and we've done approaching 320,000 vaccinations at Askham Bar now, except that's both local and national centre. And that's been supplemented by pop-ups and other PCNs working around Vale of York. When we saw the increase in cases in the city over the last few weeks, we worked very closely with Sharon and Anita, and we put up some pop-up sites very quickly. This slide just summarizes where we put them. So we had actually 9 clinics across an 8-day period, and we went to the areas where our younger populations live. So both universities, Burnholme Sports Centre, Town Hall Lane Surgery, and Jorvik Surgery, which is on Stonebow in the centre of town. And you can see the numbers there. We had over 2,000 walk-in vaccinations done in that first week. And then this week, we're back at the university, back at Jorvik, but also at Fishergate Primary School. And again, you can see the numbers there are significant, over 1,000 planned potential vaccinations. And this is in parallel to what's going on at Askham Bar. So we've got, I think this number's actually been updated now. We've got 8,000 first doses available and 10,000 plus second doses available. So there's a significant amount of supply there for our population. What I would like to say, though, is just something around the wards in the city where take-up has seemed to be low, and some of this is down to the demographic in those wards, in that many people living there weren't actually eligible until well into June. So if I take the Hull Road ward, for example, something like 50% of that population wasn't actually eligible to be vaccinated until the 7th of June and beyond. So I think it's just important to bear that in mind when we're looking at ward level data. But what I can say is this is the impact of those pop-up clinics, and you can see if we take the example of the Hull Road ward, since the 23rd of well, since the 18th of June, we've seen a 50% increase in take-up of vaccinations. And that in part, I think, has to be due to the pop-up clinics that we've put in that area. And that's compared to a 14.7% increase across the rest of the city. So I think we can demonstrate that the pop-ups and the action we have taken since we've noticed the increase in cases has had an impact. If I can just put some general data, Steph alluded to this really, but this is data from all of the PCNs across Vale of York CCG area. And I just draw your attention to the area marked in green. This is for cohorts 1 to 9. So this is our over 50s, our at-risk cohorts. And you can see there that in each PCN, the first dose percentages is well into the 90s. And you can also see that our second dose percentages is getting very close to 90% plus as well. So I think you can see that we're having a significant impact there in those cohorts. And the data I've got here, which I apologize, you probably can't see that clearly, starts to look at the younger cohorts. This is right across the Vale of York again. And if you look at in the box, I don't know whether you can see my cursor, but in the box at the bottom there, you know, first dose uptake is, once you get beyond 50, it's in the 90%, but actually down in the 40 to 49, we're at 84%, and even in 18 to 29s, we're at 60% first doses. Second dose data is obviously lagging behind that because we have to wait 8 weeks in order to give the second dose. So, but you can still see the high take up in the 50s and over. So I hope that's helpful to give you an idea of the progress the vaccination program is making, and in particular in the wards where we sense take up is low. Anita mentioned contact tracing, and Nimbus has been doing a bit of work to supplement the work that the council teams have been doing. And we're joined tonight by Will McAvoy, who's the site manager at Askham Bar. And I think Will has some data on contact tracing that he'd potentially like to share with you, if that's okay for a couple of minutes, Keith.
Yeah, hi, thanks, Mike. And I suppose just to reiterate what Anita and yourself and Penny has said, and Steph rather has said, you know, we continue to work to lower those barriers to access for vaccination. And on one of the slides you showed there, just to remind people that, you know, Askham Bar is a walk-in service 7 days a week now, 8 till 8. And I think that's a really important message for us to get out into York. You know, you can turn up at Askham Bar, have that first dose or that second dose at 8 weeks now for all 3 vaccine types. I think that's a key message for us, and you know, just continuing that success of the vaccination program. We have been working with York Council on contact tracing just to try and increase that uptake. It was particularly focused on cohorts 1 to 9. And I think I wanted to talk about a slide and some data that Peter Roderick had shared earlier in the meeting, which showed that the national expectation was about a 6% decline rate on vaccination. And I think the data we've gathered shows a similar rate of decline. And obviously we want as many people as possible to uptake on the vaccine, but I think that's a really positive figure for us. And it shows that vaccine hesitancy is not running above potentially that national average that we're seeing. So that's where we're at. And then I think also I wanted to talk briefly about work we've been doing as part of that to access people who aren't registered at GP practices, who don't have NHS numbers. I think that the pop-up clinics that we've been running at university sites have been very successful at reaching out to those groups who don't have NHS numbers, who don't have a registered GP, you know, these patients who almost don't exist potentially in this data we're looking at. And we're seeing large numbers of those patients come forward to those clinics. So I do think that as the ask changes, we're being as flexible as we can in our approach to maximize that uptake, especially to try and minimize the impact of potentially an increase in cases.
Thanks, Will.
Thank you very much to Will, Mike, Steph and Anita for that update. And I know, Mike, if possible, could we include your slides when we publish the minutes of the meeting?
Yes, I think, Keith, I think so. That data is fine to share.
That's great. Thank you very much for that. Any questions or comments from colleagues on the call? I'm sure we would all like to thank all of those involved, which I know stretch beyond NHS staff into many others, including volunteers and Nimbus Care, in making all of that possible. And certainly really pleased to hear Mike talk about the ongoing pop-up clinics and the efforts to ensure that reaches different parts of the population and the city, and good to see that data now showing the impact that is having. I'll go to Pete first. Pete.
Thanks, Keith. Just while you were talking there, I had a quick sort of book your vaccine on the NHS app, and obviously it just shows Askham Bar still at the moment. And I take it, is that because these pop-ups are just strictly walk-in? But if people are, say, in Guildhall and they're thinking, I need to book a vaccine, and they go on the NHS app and they see it's Askham Bar, they might think, no, I can't do it, and just forget about it. Is there any way of linking them into say, you know, the Jorvik on Stonebow at that point?
Mike, did you want to come back in on that?
Yeah, thanks, Pete. The challenge is that the national booking system is linked to the National Vaccination Centre, which is at Askham Bar. So that is our challenge. We're trying to publicise walk-ins, and we're trying to contact people by text through their GP surgery with the various options around the city. So we'll have a look at that and see if we can adapt the national booking system to mention these other pop-up sites. But I know up to now that's been slightly difficult because of the limitations with it being linked to the National Vaccine Centre.
Yeah, I wonder if I could just address some of that for you as well, Councillor Corbyn. When the pop-up clinics are scheduled, we do try and do leaflet drops for residents around that area as well, giving them the information that they can just walk in. So it's just trying to get that awareness around for that population as well.
Thank you very much. Fiona.
Yeah, I mean, I suppose just echo what you said. You know, it's been an amazing program, isn't it, on a scale that no one's ever seen, and you know, really grateful for all the work you've done. I suppose I just had a comment based on the data is showing that the pop-ups and taking the vaccine nearer to where people are is effective. I suppose it's just on that point of they obviously take a huge amount of work to coordinate, make people aware that they're there. And I just wonder why we haven't progressed pharmacies doing vaccinations earlier, because they are, you know, they're always there, aren't they? And they're in people's communities. And I am aware that some pharmacies had expressed interest to be able to deliver vaccine. And just a slight challenge actually on what he said, Mike, about I know for example, the whole road ward, there are a lot of younger people there, but actually when we were looking at the data uptake in the over 40s, that ward was also showing at that point of lower uptake. So there was already something there in some of our wards where, you know, that younger element wasn't leading to that lower uptake. So I think, you know, we do know that some wards people are less likely to come forward. So anything that we can do to make that local presence more long term, I think would be really welcome.
Thank you very much. Steph, I don't know if you want to come back about pharmacies.
Busy trying to find my electronic hand, so thank you. You obviously saw the confusion on my mind. One of the issues we have with the pharmacies in particular is that at the start of the programme, they were we did take a number of expressions of interest, and then as we understood about particularly the observation requirement of the vaccine, actually a lot of the smaller sites were deselected. But we are running that again just to see where we are. But we are controlled that the pharmacists are commissioned by NHS England, so they manage that programme on a regional footprint. But we are going back to run that expression of interest again. But as I say, one of the things that discounted a lot of the smaller sites was the observation requirements, but we are running that again.
Thank you very much. Sharon.
Yes, I'd just like to echo my thanks that everyone else has expressed really on how tremendous how tremendously well the vaccination programme has gone. And, you know, it's really good to hear some of the work that's going on to address vaccine inequalities. I suppose, Chair, I'm just thinking of thinking ahead to winter, thinking about you know, the need to organise the COVID vaccine booster programme as well as the flu programme this winter, and how we're going to be able to use all of the learning from the COVID vaccine programme that we've gained over the last kind of six to 8 months in preparation for winter planning. So maybe at the September meeting of the board, it would be useful to have an update on that, to understand how that planning is going, but also then to think about, as partners across the system, how we can continue to support the NHS with the delivery of that winter booster programme.
Thank you for that, Sharon. Mike.
Yeah, I'll just, if I can come briefly back on that, Sharon. I think I was at the Humber Coast and Vale vaccination board today, where we were talking about that booster program, and whilst details are emerging, it's still fairly sketchy in terms of the absolute specifics of the program. There's a suggestion that both COVID and flu could be co-administered, but I don't think we're going to get a decision on whether or not that's safe for quite some time, possibly not until October. So my sense is it could be that both programs will run separately, although that's yet to be confirmed. And obviously we've had supply issues throughout the vaccination program, and coordinating supply of flu and COVID vaccines at the same time to vaccinate people efficiently is I think will remain a challenge. In response to Fiona's point about community pharmacy, I think we'll see more community pharmacy involved as we come into the booster program. However, what we've got to remember is volume is an issue here. You know, there's a significant amount of people to get through, and therefore we all have to work together on this. And it looks like the COVID booster program will be the Pfizer vaccine, and that will still require 15-minute observation periods. So there's so many different parts to this, and the information is still slowly emerging. So we can come back and update you as we get a clearer understanding of how we're going to do that.
Thank you very much for that, and certainly I'd welcome a future update when, as you say, there's a little bit more certainty around that. So just once again to thank everybody for the work that went in behind all of those reports and updates, and thank all of those for running us through them. So that takes us now on to agenda item 6. On the timings for the meeting, I'm afraid agenda items 6, 7, and 8 are where I'm going to want to chop a few minutes. So again, just to give that warning in advance in case I do. So agenda item 6 is COVID testing strategy, and to Fiona.
I can do this very quickly. So this is really just to update you. Last time I brought details in terms of what our plans were going to be, that we were going to submit to DHSC for our testing strategy. So we've been asked to submit plans which will take us through to the end of this financial year, but on a 3-monthly cycle. So we have had our plans approved by Department of Health and Social Care. So what they do is guarantee funding for the first 3 months of that, and then it gets reviewed. So what we were asked to submit in terms of those plans was about how our local testing strategy would reach underrepresented groups and those who would be disproportionately affected were they to catch COVID. So that's what our plan is focused on. And as I said last time, we will still do assisted testing for those populations who are unable to do it themselves. So we have St William's College, Foxwood, Acomb Explore, York St John University and the University of York, where people can still have a test done. We will be looking for a venue in the Rawcliffe area, which will replace the community stadium testing venue, and we hope to have that open within the next couple of weeks. But then the rest of the bulk of our testing work will be reaching out into communities. So we continue to do door-to-door delivery of test kits and conversations with members of the public, and we include vaccination in that as well. When we're talking to people, we ask them if they've had a vaccine. We also hand out test kits at any of the vaccination sites, and some of the pop-ups that have happened as well, just to remind people that when you're having a vaccine, it's still advisable to continue regular symptom-free testing. And then some of the additional work that we've been doing is with groups such as the York Travellers Trust, Tang Hall Community Centre, Refugee Action, the York Interfaith Group, and the food banks, to kind of reach into those communities where they may not be aware of the testing offer and would be disproportionately affected if they were to get COVID. So it's we continue to do that work, and we still have a good uptake in terms of people who are still wanting to know what their COVID status is and make sure that they protect friends and family. Thank you.
Thank you very much for that, Fiona. So obviously, I'm sure we'll note that information, including that welcome sign-off from the Department of Health, just to check if there are any questions or comments from colleagues. If not, thank you very much for that, which now leads us straight onto agenda item 7, which is the communications update, and I'll hand over to Gareth. Welcome.
Thanks. There's some slides that go with this, Richard. If you could present them, thanks. Okay, mindful of skipping through things. Can we go through to, there we go. So, well, just a reminder, these are the key behaviours that we're promoting and remain the ones to promote until at least July the 19th. We're obviously awaiting further government guidance following recent announcements. Can we go next slide? And just a reminder, we're firmly in that phase 4, the safely recover phase. And the next slide just outlines the communication approach to each phase. Just a reminder, phase 4 follows the same approaches that have served us well throughout phases 1 and 2, timely and accurate information, partnership, and confidence in those behaviours that people need to exhibit. That will have harder in step 4, I think, as we discussed earlier in today's meeting, around the guidance is likely to place more emphasis on personal responsibilities rather than uniformity. Next slide, please. And this is just the work programme. So this is an updated one just to reflect, and it's worth looking at how far in advance we have to work. It does reflect that message from the government, and it's been clear this meeting earlier is that the pandemic's far from over. The particular comms focus will be on supporting residents, businesses, schools and other stakeholders just to continue to do the things that keep York safe. So focus on vaccinations, testing, etc. Also an increasing focus on recovery and addressing the impact of the pandemic. Most notably, emotional health that's come through loud and clear again today. Feel Real York is the campaign giving support and advice to anyone struggling with their mental fitness. There's What's My Next Step is a new campaign, but I'll cover that later in the presentation. Next slide. So these are the steps. Obviously, they're not confirmed yet. That will definitely go to step 4. We'll find that out on Monday. Next slide. And again, thanks. So just the sharing of timely and accurate messaging. Our media releases are a decent proxy of the wider comms activity and the importance of various things within the city. This continues the recent trend that we reported in the last couple of boards. Lots of business as usual coming in to join the COVID-related activity. Less than half our press releases, again, were about COVID, and a large proportion of those are focused on recovery and support for residents and businesses, so school leaves advice, emotional health support, and so on. And worth noting that just a third of our media inquiries have been about COVID-related work in last month. Next slide. So this just covers the rhythm of our comms. It will continue in a similar vein. It's likely to intensify as we approach step 4. Again, it's a broad mix of opportunities for residents and stakeholders to get the info they want and need. Given time pressures, I won't dwell on this. Should we go to the next slide? and nor this presentation was submitted prior to Monday's announcement at 5 o'clock. So we'll have to update that now we've got a better idea of what step 4 is all about. Thanks, Richard. And again. So one of the key things we had to communicate last month was the obviously delay in moving to step 4. We did respond to I'd say a large amount of disappointment with the decision, but focusing our comms once again on what people needed to do, the behaviours that we needed to promote. So key behaviours, hand space, fresh air, testing and the like. Next one, please, Richard. And all this was happening against the backdrop of rising cases nationally and in York. So these are just some of the things we did to remind residents of the practical steps they can take to reduce transmission and the impact that has on life in the city. Here's a couple of key examples. So these are letters offering practical advice both to head teachers and to parents and carers, accompanied by a leaflet that we distributed last week. There's also a reminder about enjoying England's running the Euros safely, identified as a bit of a risk as people mix more freely. Next slide, please. So this is about testing. So these are just the examples of activity to support that new, more community-focused testing strategy. We're ready to do a lot more to support the new work just outlined by Fiona. But by and large, we've been doing leaflets to support door-to-door activity, another letter to parents shared by schools, which was a different message about the importance of maintaining testing. And then we've been using national messaging to clear up any confusion about when to use a home test and when to go to a testing site. We've also been putting this information through every letterbox in the city over the last 2 weeks through the Our City publication. Next slide, please. So vaccinations, as Anita said earlier, we're working with NHS colleagues to support the unvaccinated to get a vaccination. Comms is obviously one part of that complex picture that's emerging as we get more insight as to what the barriers are. The impact was covered earlier in item 5, so I won't go into much detail about that, but there's just some examples here, how we've pushed the Grab a Jab campaign. In keeping with making the process as simple as possible, we've shared daily updates through social media about where those pop-up clinics are and when, just trying to get the message into people's thought processes at the time they're actually making their plans for the following day. Social media boosting has also allowed us to target locations and populations. So we've done some paid for advertising on Instagram just to reach younger people as the vaccine became available to them. And as I say, we've seen the results in the figures shared earlier, and we'll continue to work with our health partners to keep changing that message to increase take-up. Next slide, thanks. So this is what I referenced earlier, what's my next step. There's a new campaign that we launched last week. There's rightly been a lot of focus on mental health work, but there's also been an impact on physical health during restrictions. Many people have lost fitness, muscle strength and core strength, and that presents obviously a risk to them personally, but also pressure on the NHS from falls and other complications caused by a more sedentary lifestyle. We've partnered with the CCG and hospital, including like physios, full practitioners team, Live Well York, North Yorkshire Sports, Age UK, CVS, a lot of partners, some who I may have just forgotten, but right across the council, health and voluntary sector, we've developed and delivering this campaign just to build activity into people's everyday life. The visuals show some of the simple things that you can do in your own home with no special equipment. So this inside the home toolkit will be followed by campaigns promoting things to do outside the home, and then as a third stage, things to do to get more active and social. Given the audience, we're matching online work with a lot of significant offline presence. So you were using Our City again, a lot of print and targeted broadcast media interviews. We've got hard copies of these guides have gone into all our independent living communities, and we're also working with other community-based support services and organisations like the falls practitioners, physiotherapists, just to get that info to the people who will benefit most. We have got other activity planned as well, including our travel colleagues will be taking a stall at the in the hospital foyer soon. While we haven't got a slide on it, I will just quickly mention Feel Real York, the emotional health campaign. It's been a series of toolkits that we've shared out through partners, following the 5 ways to wellbeing. That's connect with others, be active, learn new skills, give to others, and be mindful of the present. The most recent toolkit we shared was around supporting men's mental health and assets, which have been encouraging empathy with people struggling to come to terms with the end of restrictions. Next slide, please. And again, now this is just a reminder of the about the Public Health England behavioural insight work. This is what this the activity to date. It's just worth noting on here there hasn't been a huge uptake in participation in the research. We've of the 15 people who registered an interest, we only resulted in 8 detailed interviews. We've also had around 200 respondents to our cities taking the temperature survey, which was in the spring edition. And now that compares to just under 2,000 respondents to the first taking the temperature survey we did the same time previous year, just as we came out of the first lockdown the previous year. That low level take up in itself does chime with wider insight and feeling that many in the population are feeling a much lower sense of personal risk buoyed by the success of the vaccine programme. Can we go to the next slide? But that said, the Public Health England's Insights team did use those interviews to provide us with these recommendations around the measures and changes to signage that we should have in York. I'd really like to thank them for their willingness to work with us. They've put a lot of effort into the recruitment effort and into the report itself. It's very detailed and useful piece of work. So while the small sample is highly likely to have been more cautious than the wider population, and is tied to the observing or attitudes towards restrictions, which might not exist in a couple of weeks. These are really useful for us as starting points for conversations. That the views definitely reflect significant perspectives felt within our communities. We're seeing it across the conversations taking place about lifting restrictions and some of the contributions to the conversation that was had earlier about caution around mask wearing, around crowds, lessons about the size and positioning of our signage are really important, and expectations around hand gels, what people will expect to see that might be seen as COVID measures, but beyond the lifting of restrictions. And we're using this insight to start conversations with a lot of stakeholder groups, including the Tourism Advisory Board last week and others who we're meeting with this week, who will formally share these findings with and have that as a starting point for that conversation around what they expect from us and what they'd like to see in the city. Can we have next slide? This rather complicated group of pink boxes just shows that process that we're going through to develop any required local messaging or campaigns for York. So we're working with stakeholder groups like the Tourism Advisory Board, as I mentioned, and as Councillor Ashton said earlier, with that comms group that we've managed to pull together over the last couple of years, with very willing and helpful and supportive organisations across public, private, and voluntary sector. We'll be led by partners. They'll tell us what they know, what they expect from us and from the city, and obviously our Director of Public Health will make sure we're hitting the right notes around behaviours needed to keep residents safe. I think you've said that you want to bring this back in at the next one for a more detailed discussion of what that looks like. So just to reiterate, I think what you were discussing earlier is clear from the initial conversations. There are a really broad range of perspectives on the end of restrictions, a lot of uncertainty as to how people will respond to that. So central to any campaign, it's clear that there will be a reminder that people have experienced the pandemic in very different ways, and there'll be a lot of anxiety to accompany the celebration in some quarters. So we're fairly sure that kindness will be a very important part of any campaign, and just empathy around why people are making the choices they're making about the safety of themselves and others. So just to say as well that it's really, really important that we get it right. So we won't be rushing it, and we'll be prepared to respond quickly to whatever picture emerges beyond what could be July the 19th. I think that's it.
Thank you very much for that, Gareth, and again, all of the work that I know goes in behind the presentation. I was pleased to see Carol there doing some gardening. I won't ask you
I
what.
didn't know whether to point out that we had a model in the board.
Thank you very much for that. James.
Yeah, thanks for that, Gareth. I think we're probably moving into the phase which is probably the most confusing for residents, given you've got the numbers rising, coupled with this personal responsibility, whatever it means, and the messages coming out of government as we approach the 19th. And there's also going to be the tensions, I think, as he pointed out towards the end, around, when you talk about personal responsibility, what one person deems that will be conflicting with what another, and it could cause tensions in the community. I just think it'd be really useful to have some very simple, plain English messaging that we all use and we all utilise in the same way. So we're all saying exactly the same thing in exactly the same way about what were expectations. So picking up on that empathy point and some of the other key messages, I think it's become very kind of difficult to understand what you're actually supposed to do and what you're not supposed to do, and making sure we're all speaking the same language in the same way in a coherent manner, I think would be really useful.
Yeah, that's absolutely the idea, and that's why we want it to be to have as much partner input as possible, and obviously everyone on this board will be invited into that conversation.
Yeah, certainly, completely agree, and hopefully we can do some of that work and then bring some of the further examples back to that board meeting. So thank you very much for that presentation, which now takes us on to agenda item 8, which is the update from the Universities and Higher Education group, and to Charlie.
Thank you very much, Keith. I think Gareth used the phrase in his presentation, something about enjoying England's run in the Euros. So I'll be quick. The report's the report. What's happened since? The numbers have gone down in terms of cases. I think there was one recorded at the University of York today. So clearly way beyond that peak, and the vaccination numbers have gone up with another clinic this week, as one of the pop-ups we heard from earlier. So those two sets of numbers are going in the right direction. The big news, of course, is the government announcement. Prime Minister's on Monday, and the general changes there affect us. And then we had specific Department for Education guidance yesterday, both for 19th of July and thinking ahead towards September. In large parts, that was an uncomplicated, I won't say unproblematic, but uncomplicated translation of the general guidance to the university setting. There is in that a general commitment not to treat universities and students differently than the general population, which is welcome. But of course, they don't stick to that in the guidance. Partly for good reasons. There is a sense of having an intensive testing regime at the point of transition of household in September, which seems to me to be sensible. There's some odd stuff in there as well. I've corresponded separately with Sharon. The COVID app check-in system is generally abolished as of the 19th of July, but apparently it will need to be used for access to any university facilities or teaching rooms in which there will be social contact. And that actually makes very little sense to me. It's as if the government doesn't quite know how many rooms we have in which people congregate. So I suspect there'll be a few issues of clarification there. One or two quite unhelpful things. There is a passage which says, I can find it, no student should be denied education on the grounds of whether they are or are not wearing a face covering, which is effectively, it's a much stronger message than we would like, because I think we would like the opportunity to encourage face mask wearing as a continuing protection measure. So there's a few odd things, a few dissonant things, but we'll work through them. And we'll renew all of our health and safety risk assessments in the light of the post 19th of July situation. We'll have contingency plans for if if there is a local or a national problem which leads to the reintroduction of restrictions. And via Sharon's team, we'll be doing some desktop scenario exercises probably early in August. I think the relevant people are all in place then, just to think through some of those possible scenarios, what we'd do with outbreaks and so on. So we're digesting the guidance and trying to make sense of it, Keith.
Thank you very much for that, Charlie, and all the ongoing efforts to make sense of it, as you say. And thank you for the paper that was in the pack as well. Pete.
Thank you, Chair. And at the risk of worrying all the football fans, I do have a question. I'm not a football fan myself. I follow Everton. Charlie, what do we do with, or what's happening, or how big a problem is it for students who are isolating as their tenancies come to an end, especially if the landlord is insisting on them vacating the premises? What's happening around that?
Depends where students live, is the answer. We have currently, let me have a look, 94 students self-isolating on campus, and some of those will now be going on beyond their lists, and of course we are extending that without charge, as well as of course supplying the students with food and digital vouchers and daily welfare calls. We have worked through, I can't remember if it was your team, Sharon, or through your team's good offices, to engage with private landlords across the city and to ask them to be both understanding of the situation students find themselves in, and to recognise the public health issues, because if they wanted to chuck students out at the end of their lease, they would be in effect encouraging students to break the law. We would also like them not to charge. And given that there should in most cases be a bit of a buffer period between exiting and entering students, it shouldn't be that difficult to manage. I have heard, or I've asked my colleagues to tell me whether instances have arisen, and not many, and certainly less than in other university cities. There have been the odd case where a student has reported that a landlord isn't showing that level of understanding. They've come to us, they've got advice from us and support from us. So as far as I have been told, this is not presenting as a big problem.
Thank you, Charlie. Sharon, you wanted to come in?
Yeah, just very quickly, Chair. I mean, I would absolutely support what Charlie has said, and we're working with York St John University and the colleges as well, where this has been an issue. I've personally had to intervene with 2 landlords, I think, who were being particularly difficult about this. But I think it was just their lack of understanding of the legal restrictions around social isolation, and helping them to work through the problem where they've got new tenants who are about to come into accommodation, but they can't because others are self-isolating. So we have got the support in place, Pete. It's only been a small number of landlords where we've had to intervene. Most are being very cooperative. And as Charlie has said, there is support for students, and there's also financial support for students in private rented accommodation that we can provide through the COVID grant as well. So we've got extensive support networks in place, including for dealing with international students, where we've been contacted by the parent or a relative of an international student in York that's needed support. So I'm confident that there shouldn't be any students who are experiencing difficulties without support being there for them.
I should add, Sharon, as well, that if we do see that situation where somebody's overstaying their lease because of COVID self-isolation and somebody has turned up through, perhaps they've flown into the country, couldn't change flights and so on, we will certainly provide short-term accommodation on campus to bridge any short-term needs.
Thank you very much for that, Charlie and Sharon, and as I said earlier, Charlie, for that report. I'm going to swap the next two agenda items around, and hopefully it will make sense why. So agenda item 9 is dates of future meetings. Our next meeting is scheduled to be on the 29th of September, and then monthly afterwards, because we do not ordinarily have all of our meetings in August, but I know partners on the board have expressed a wish, particularly because of the lifting of restrictions, to put in an extra meeting in late August. So I can see a few nods. So that's going to be my proposal, that we stick to the scheduled meetings as we've got, but that we add an additional meeting in August. So thank you for the nods on that. And if I could take that as agreement on agenda item 9 with that extra meeting, then I'll go back to the earlier agenda item, which is items for the future agenda. We've got the suggestion that the September agenda has both the standing items and also we've got planned to have the impact survey update from the voluntary sector and an update on the economy and building back fairer, and also a further update on the role that community hubs can play in the recovery section. So quite a busy September meeting, and in August for that extra meeting suggest a sort of 3-item agenda where you've got the regular update on COVID, update in York, and we could have an item looking at the easing of restrictions and the experiences that we've had in York, particularly, for example, looking at businesses, the economy, and then a 3rd item looking around communications and what support that we can give to the different communities in York because of that easing of restrictions would be my suggestion. Happy, obviously, to take any additional items for that August meeting. If not, do as normal contact Tracy outside of the meeting if there is any extra items for August or for September. And with that, hopefully we can agree those items. And then the final item is any other business. I think we've covered everything elsewhere under the agenda, and I'm not aware of anything else. I can see Sharon shaking her head. So there's a few references. Some of us might have our televisions on in 30 minutes time, but just to say thank you all for your time and input and all of your questions, and also your agreement to have that extra meeting in August as we move through this next phase. Thank you all, and also to Mark, thank you for your input up to now. Thanks all. Bye-bye.